Pleasure to go ahead and introduce Dr. Antonio Santillan Gomez, who is our guest speaker this morning, talking about technological change, primarily robotic surgery. Dr. Santillan grew up in Monterrey, Mexico, and went and did his undergraduate and medical school at the medical school in Monterrey. He then did his residency in obstetrics and gynecology at the University of Oklahoma in Tulsa. He then did his gynecological oncology fellowship at Johns Hopkins, where he also received an MBA. He then joined the faculty at Texas Tech University in El Paso, and more recently moved to San Antonio in private practice. And we are happy to have him here this morning to talk to us. Dr. Santillan.
Well, good morning, everybody. I know it's going to be too early, and hopefully I don't bore you with all, these slides. Today, we have exciting times in surgery. We have new technology, mainly robotic surgery. So the objective of this presentation is trying to present, some of the applications, some outcomes of surgery, and then we'll try to discuss some of the benefits and the disadvantages of these new technologies, and what we're going to be facing in the future. Two disclosures. One, I'm a proctor for Intuitive Surgical. Proctor means that I help, new trained robotic surgeons to start their, robotic career, if you want to put it that way. I do, that quite often. Also, I was going to say the youngest, but I'm the older brother of Dr. Alfredo Santillan, which is one of your faculties here at the university. So robotic surgery, what we want to know is that robotic surgery was not only developed to overcome the limitations of minimal invasive surgery, but also to enhance the capability of open surgery. And I think this concept is really important. So it was not only to replace laparoscopy, but to make open surgery or to enhance those capabilities for open surgery. So in the past 25 years, there has been a sort of sophistication of robotic technology, mainly in the concept of robotic telepresence technology. This was born by a collaboration of the Defense Department, the Stanford Research Institute, and NASA. And the main objective or the main plan for this technology was to provide operative care in the battlefield with robotic appliance mounted in armed vehicles operated by surgeons in a protected distance. So the first application, or the thought of the application for robotic surgery, was actually for trauma surgery. This was the first, thought about robotic surgery. While the research, in the research and development in the battlefield and remote surgery continue, the only applications that we have right now in robotic surgery is for the civilian population. So I want to show you, a little video about what they thought, what they wanted to have in the next years about robotic surgery. So this was the original plan. It's for everybody to wake up a little bit.
Man down, man down. Medevac, medevac.
The ambulance of the future, probably.
Scanning. Forceps.
5-minute surgery, huh? How about that? Now we can go home early after that. Yeah. All right, so that's what the intention of robotic surgery. Impressively, well, that may happen in the future, that continue to develop, but right now we have some of these telepresence technology now today, and it's been applied in many of the surgical fields. The main application has been for urology, gynecology. There has been limited application for general surgery, but it has been increasingly getting into other fields, cardiac surgery, thoracic surgery, etc. So one of the things, everybody knows there's a lot of controversy about this robotic surgery. There's a great debate about the outcomes of robotic surgery, but there's also some benefits about robotic surgery, and some of those benefits has been clear of the debate, and the main one is the similarity with laparoscopy surgery. The similarity with laparoscopy surgery is robotic surgery is still a minimal invasive surgery. So the outcomes that we see now and then on minimal invasive surgery may be similar, if not better, a little bit with robotic surgery. So robotic surgery continues to be a minimal invasive surgery, has the ability to operate through a small keyhole incisions. Still, the camera and the instruments fit through those small keyholes, and it will get a better visualization than open surgery. So the benefits for minimal invasive surgery, and this is including laparoscopic surgery and robotic surgery in general, is reduced blood loss, fewer complications, decreased length of stay, fast recovery, less risk of infection, improved cosmesis, significantly less pain. So we know, and all that has been well documented for all the minimal invasive surgeries among all surgical fields. Now, what are the drawbacks from conventional laparoscopy? So what do we need a new technology? Well, what do we have right now? The conventional laparoscopy, what are we doing? We're doing the surgeries being a 2D image. There's limited range of motion. One has to depend on an assistant carrying on the camera, mainly the intern. So we have to have a lot of dependence on that assistant to carry on a complex surgery. Sometimes it's difficult. But also there's also implications within the surgeon. It causes great fatigue to cause laparoscopic surgery, more for complicated cases or long procedures. So that also we're going to get a toll in the longevity of the surgeon. So how we can overcome those drawbacks? We'll just go opposite for those drawbacks we have. If we could have better visualization, if we have a better instrument control, better dexterity, better ergonomics. So the only FDA-approved system of technology that can overcome those drawbacks is the Vinci robot. That's the only thing, the only one in the market, so the only one I can talk about. So what's the Vinci system consist? It consists in a operating platform. That operating platform has 4 arms. One arm is a camera. The other 3 arms are remotely activated instruments. All the instruments has the EndoWrist technology, which basically mimics the open surgery or hand surgery that we do in surgery with 7 degrees motion of our wrist. Also has a 3-dimensional imaging, which is a better imaging than what we do in conventional laparoscopy. We can see the depth of the tissues and some other things. And it has ergonomic comfort for the surgeons. We do these procedures basically sitting down. What's the OR configuration? The OR configuration varies depending on what type of surgery. It can be between the legs. It could be in the right upper shoulder, depending on where you can move the robot. The operating platform can be completely moved all around. Usually there's a surgeon console in which all the movements are performed. Since that console, all the view and mobilization is often, and it's close to the operating platform. One of the things that is important here is the assistance, or the amount of assistance that you need to have to perform robotic surgery, which is basically one or two. So just a first assist. This could be a surgeon, a first assist, a nurse practitioner, even a surgical tech. Doesn't even need to be a physician to be as a first assist and helping in this surgery, which that allows and free up another surgeon not to be in that OR. So what's the endo-wrist technology? Again, we have these free movements of the wrist so 7 degrees motion. So it mimics what we're doing in open surgery. So you have, compared to conventional laparoscopy, your hands and movements are less awkward. You don't need to see in a mirror images to do your surgery. So it's an easy way to perform surgery. So what applications, where this robotic surgery is being applied today? As I mentioned at the beginning of the presentation, the applications are mainly for urology, gynecology, with limited applications in general surgery, otolaryngology, cardiac surgery, and thoracic surgery. It's important to talk about some of these applications and outcomes, mainly on those where we have more published information and data on outcomes. I think it's worth it to mention that the urologists were the first one to adopt and to champion this technology. They start doing different procedures, starting with prostatectomies, now to nephrectomies, donor nephrectomies, dismembered pyeloplasties, and urethral reconstruction. If we do a fast review of their outcomes, we can say that overall the outcomes may be similar to laparoscopic surgery or minimal invasive surgery, maybe increased advantage in some of their specific outcomes for specific procedures. The most important outcome that we can consider is the adoption. When we try to compare robotic to laparoscopy in physicians that perform a lot of concentrated laparoscopy and robotics, maybe the outcomes may be similar. The problem here is how we can, how can we expand to all those other physicians that do not do laparoscopy. So in the case of radical prostatectomies, the use of minimal invasive technology or surgery was relatively low by the year 2001. By 2001, the number of robotic cases was 1%. By 2010, it's almost more than 60% of robotic of cases for radical prostatectomy are performed with the robot. It continues to be open surgery, the gold standard, but many of the institutions that concentrate high volume for prostate cancer have been using laparoscopic or robotic prostatectomies as a standard of care. With respect to the outcomes on prostatectomies, briefly, we can say that they look for 3 different outcomes: the operative outcomes, oncological outcomes, and functional outcomes. And basically, those are the type of outcomes we start looking in other surgical fields and other type of procedures, more when we're talking about cancer. So on the perioperative outcomes, as we can see, they're the same outcomes that we obtain with minimal invasive surgery or with laparoscopic surgery: less postoperative pain, reduced blood loss, decreased hospital length of stay. I think that's about all the surgical fields. In the oncological part, which is really important, again, there's no difference in the amount of lymph nodes yield, positive surgical margins, biochemical recurrence in the current studies. In the functional aspects, they may be a little advantage in robotic surgery in 2 main aspects for prostatectomies: one in urinary incontinence and erectile dysfunction. But again, may not be as different as for laparoscopic procedures. In gynecology, I think this is the second field that had a high adoption of the technology after the urologist, mainly for gynecological cancer. But after gynecological cancer started also spreading into benign conditions. Here in this slide, what I want to show is this study that was presented in 2011. I think it's an important study. It's like the first 1,000 cases of one institution reporting their experience of those 1,000 cases. What is important to see here is the trend of minimal invasive surgery within the years. From the year 2005 to 2006, most of the minimal invasive surgery was done by conventional laparoscopy. We can see that after 2006 and 2007, with the adoption of robotics, the increase on procedures went significantly higher within time. So there was more adoption of minimal invasive surgery due to robotics than to conventional laparoscopy. Specifically for cancer staging, for uterine cancer staging, endometrial cancer staging, we can see the same growth in the minimal invasive procedures when there was adoption of a robotic program in that institution. We can see that from 2005 and 2006, we have a 6.4 percent of minimal invasive surgeries, probably with conventional laparoscopy, and now 80% of the surgical staging for endometrial cancer is performed, again, minimal invasive, but with robotic surgery. So that's a big growth due to the robotic surgery. What is the experience on complications in 1,000 cases in a concentrated GYN oncology group? Well, it's a low complication rate of 5.7% of complications from 1,000 cases. One of the other aspects that we can discuss in gynecology, and again, I'm talking about gynecology and urology because most of the published data that we have on robotics are in these two fields, and this is the only thing scientifically that I can present when talking about outcomes in robotics. One of these is, again, the adoption of minimal invasive surgery at the Brigham and Women's Hospital. And this is, again, a publication from 2011. What is key in this publication is the difference modality for minimal invasive surgery for performing hysterectomies compared to open surgery within time. And here within time we have two columns. We have 2006 and 2009. In that way, you can compare, learning curves from that time to, more robust programs until 2009. And what we can see here when we compare laparoscopy from robotic surgery, we have a less rate of conversions. So, and mainly within time, when after the learning curve on robotics, we have now 0 conversion rates. It's important to mention that most of these surgeries are GYN oncology surgeries, radical hysterectomies, endometrial cancer stages, and more complicated surgeries than just a regular hysterectomy. Also, there's less or decrease in the major complications and decrease in the postoperative complications. As we can see, the length of stay is obvious, the decrease from an abdominal open surgery compared to laparoscopically and robotic surgery. Now, in general surgery, as mentioned, the publications in general surgery actually are limited. Most of the publications are just case series or reports on how to perform a specific procedure within the robot, but it's been growing and it's increasingly being explored more and more every day. The fields with more interest is for foregut surgery, endocrinology surgery, bariatric surgery, and hepatobiliary surgery. One of the things is, like, I was talking to a surgeon and say, well, the most common procedure that he performs is a cholecystectomy. And he was starting to do robotic cholecystectomies. And I say, well, why you want to do robotic cholecystectomy? You can do that faster laparoscopically. So, and he starts explaining, well, I want to offer a new technology for my patient. And even though I'm a robotic, again, favor or bias against robotics, I was telling, well, but you cannot do this procedure laparoscopic. It's a simple procedure. So overall, there's no advantage over a standard laparoscopy approach to perform a cholecystectomy due to the robot, unless we start using single incision laparoscopy. And we're going to talk a little bit about that, but that's just a different approach, again, with different recommendations and indications. It has been shown that robotics in these situations for cholecystectomies, splenectomies, and colectomies increase the operative time observed. Precise dissection is not necessary, so the robot may not be as, maybe overused. And there's some limitations with the spaces due to the broad sweeping motions of the robotic surgery. In the case of Nissen fundoplication and Heller myotomy, the results have been comparable between laparoscopy and robotics. There's a small series also in robotic gastrectomy and gastrectomies for cancer. Long-term survival is still not yet available. Again, this is our early pilot studies. There's some case reports indicating safety and feasibility of complex esophagectomies. This has had better outcomes due to the high morbidity of open procedures when these are performed. In hepatobiliary, there has been robotic hepatectomies, lobectomies, segmentectomies, all described and appear to be safe. Due to their complexity, they are rarely performed with conventional laparoscopy, so that's a big advantage for that specific type of procedure. In endocrine surgery, and this is something that that I wanted to show. As some of you know, my brother do robotic adrenalectomy. So I was looking into how much data we have in robotic adrenalectomies, and there was a small randomized clinical trial comparing laparoscopic versus robotic adenectomies and found that robotic approach had more morbidity, cost, and operative time. What is really important to mention here, this was done in 2004. So in 2004, it was just the beginning of the robotic programs. So this was, I think, an early or precipitated study compared to the mature robotic programs of now today. You can see after that many other case series showing the feasibility and safety of this approach. There has been also other case series that have been published on robotic pancreatectomies, pancreatic duodenectomies, thyroidectomies, transaxillary, which has not been compared completely to open surgery. I don't know how many of you remember, but last year my brother presented almost at the same time grand rounds, and he talked about what was new in thyroid surgery, and basically his whole talk was focused on robotic thyroidectomies. So I don't know how many of you remember this, but I'm going to show some of his slides from last year. So this is basically his summary about robotic thyroidectomies. Robotic thyroidectomy is still in search for an application and indication of the United States. There's a few centers that still do robotic thyroidectomies, and honestly, as well he probably presented last year, is not becoming something that is having a great adoption. It's feasible, has some obvious cosmetic advantage, but it's very complex procedure, and the learning curve is at least 50 cases. So you have to be in a high volume concentrated center to actually be feasible to do these type of procedures. So his opinion last year was open thyroidectomy is an excellent operation and it's hard to make it better. And then he has some quotes. His opinion about real estate was location, location, location. His opinion about airlines was safety, safety, safety. And his opinion about surgery was exposure, exposure, exposure. So he was not an advocate for robotic surgery at all. Actually, at the same time, we did a case together of a robotic surgery. I was doing a robotic surgery, debulking for a lymph node and concealing the iliac vessels. And I thought I was going to, shock and awe my brother. At the end of the surgery, he said, "I'm not impressed." So that's okay. It's my brother. So what other things have been happening new? Like recently, there's an FDA-approved equipment only approved for cholecystectomies and to perform SILS or single incision laparoscopic surgery using the robot. One of the disadvantages of this new technology is that does not have the endo-wrist facility that we use in pelvic surgery and other type of surgeries. So it's still a rigid remote control instrumentation. But in the future, probably it's going to have the endo-wrist ability, and it probably will have an expanded scope more for inguinal hernia repairs. Also, it's been used for hepatectomies, etc. In bariatric surgery, I think this is really interesting. Most of the applications of surgery has been in all those procedures where there's that require more complex intracorporeal sewing. So bariatric surgery was one of those areas that needed to be explored. In one of, again, early studies from 2005, and this is really interesting because this is a study made in an academic center with fellows, and they did a small trial in which compared the first 50 RX-and-Y procedures randomized for laparoscopic and robotic, and they saw that they can do their hand-sew anastomosis faster with the robot. So what conclusions we have with that? That the robot enables these early starting surgeons to perform their surgeries more proficient and efficiently than waiting for a learning curve of 5 years after finishing fellowship. So the robot could be an enabler or facilitator to try to create similar outcomes. In colorectal surgery, there's more data in colorectal surgery, specifically for rectal cancer. There's a small comparative trial of robotic versus laparoscopic total mesorectal excision for rectal cancer, with some benefits of robotic surgery with length of stay and similar low complicated rates. In the case of robotic total colectomy, this is still an area which is a little bit limited. You have to move the robot, conduct the robot multiple times, and that increases the operative time. So it's a little bit more difficult than performing just laparoscopically. Discussing or looking into that rectal cancer data, I think it's really important to mention that when compared to laparoscopy, there was increased in some of the series, early series, increasing the operative time, but in 2 of the series with more number of patients, actually the operative time with robotics was even lower. And we see that in gynecological cancer surgery, in which we perform robotic radical hysterectomies in a lesser time than when we do it actually open. So you get more proficient, you get better, and you can do the performance even faster. And that's also been the case for pelvic surgeries, or in this case, rectal cancer surgery. One of the important things on these studies is that most of the use of robotics in rectal cancer has been on patients that had prior chemoradiation. So those patients that will be difficult even to do laparoscopically, they've been able to be performed with proficiency with the robotic technology. In outcomes, there has been no difference in oncological outcomes, and there was no difference in anastomostic leaks in a review of studies for rectal cancer surgery. So what's the experience here? What's the experience of a robotic rectal cancer surgery? After that presentation of thyroidectomy, after that visit of my brother to OR with me, my brother became certified robotic surgeon. So being an excellent surgeon, now he became a master surgeon. So he went and had a 1-case learning curve to perform rectal robotic surgeries. And that learning case was not with a human, it was with a pig. He went to an animal lab, he went his animal lab training, came back and did a rectal cancer surgery. And these are some of the results that he had in his first 6 cases. So adequate mobilization of the colon, complete excision of the mesorectum and rectum, and in a minimal invasive approach. Before that, he was not doing any of this laparoscopically. Okay, so 1 animal model for his learning curve. So, what's his opinion about real estate? Location, location, location. His opinion about airline, safety, safety, safety. And his new opinion on surgery is robotics, robotics, robotics. So we have a change in time in less than 1 year. And believe me, I've been doing robotics almost now for 5 years, and for 5 years, he didn't care. So, what new technologies are going to become to make this better for the field of general surgery? So right now we have new technologies we're using. As mentioned, there's an FDA approval for single incision for cholecystectomies or hepatectomies. There's also a new advanced sealer, meaning that we have a reticulating bipolar cautery or tripod in which we can coagulate bipolarly and cut. There's also going to be advanced stapling devices for gastrointestinal surgery coming in the next few months. So we're creating some advances. When we talk, we also have some enhanced visualization and other things we're doing in imaging that still that may improve some of the oncological outcomes when we're talking about lymphatic resections, etc. One of the other important aspects is the education and the education of residents. You know, this technology provides now a simulator which has a similar kit. It's like you have like your own Nintendo in which you can play and simulate, you know, in the robot without being using a patient. And the movements are similar. And we have tried that skill simulator, and it actually is really accurate on what we do in real surgery. So overall, robotic surgery, the benefits, you know, increased precision, it's physical easier, so we can do all those complex procedures that we didn't want it to do laparoscopically now in a minimal invasive way, has a 3D high definition visualization, reduce the trauma, etc. So we talk about all those advantages, but we need to focus on the disadvantage of robotic surgery. The most common disadvantage or the most common concept is the cost. What's the cost of the technology? If it's really worth it to do this versus traditional surgery. Also, it removes all physical contact from the patient. So what's the safety of this area? Take nearly twice as long, and I think that's controversial. For me, it takes twice less when I do my robotic cases than when I used to do them laparoscopically or open before. It takes up a lot of space in the OR. Again, we have modified some ways on what things needs to be in the OR to try to not have that problem. But one of the other problems is all operative instruments are not compatible. So right now it's the only technology, so there's no competition to provide other alternatives to this. So that may be a problem in the future, may be resolved. So when we change medical technologies, again, one of the main things that we have to look into is the cost. and the cost of these technologies? Well, first of all, if there's any different of outcomes, if there's improvement of outcomes or similar outcomes, and two, what's the cost of this technology? Do they decrease the overall cost of healthcare? Who receives the savings or who bears the additional costs? So are the things that we need to ask, when we're changing technologies. It's really important to remind also that we're going through a, economical crisis. The expected healthcare spending by 2015 is going to be at least $4 trillion, 20% of the GDP. The cost of the hospitals is 40% of that healthcare spending. So when we're talking about equipment and all that, that goes into that cost. And so those are the things that we need to be looking at when we're talking about new technologies. Briefly, I don't want to bore you with like a financial class or MBA class here, but really fast, there's the difference between cost and charges. Cost is the real numbers on how much things cost. Charges is a calculated it's a calculation from the service, from the indirect cost and profit margins, including to the cost. It's easy to collect the charges when we do an analysis, but it's not as accurate if we have the cost of the technology. So some of the publications that we do are based on charges and make a calculation of cost more than the directed cost itself. So how much the robot cost? Well, these cost between $1 to $1.5 million start, and also 100 to 150K a year of maintenance. It has disposable instruments. They have those disposable instruments have like a 10 times life, so you can use in 10 surgeries, but there's disposable. And you have to have these routine maintenance and services. In average, the increased cost per case is around $1,600, so 6% increase in cost. If you add the cost of the robot, the cost of the equipment, and you amortize that within time, it's at least 12% increase, so to $3,200. So these costs. So where's the cost? Savings when when you're using a robotic program. If the equipment is so expensive, well, the cost will decrease depending on the length of stay. So most of the focus of the cost in robotics is decreasing the length of stay. So one can say, well, if I do laparoscopic surgery, I decrease the length of stay. Why have to do robotics? I can decrease the cost doing that. In robotics, length of stay will only decrease, and the financial number at the end will only decrease depending on the scale and the volume of robotic surgeries performed in that institution. Again, what is really important is, yes, when you compare robotics and laparoscopy, is, well, how many laparoscopic cases you do compared to robotic cases. What do I mean? If at a certain point of time, the number of minimal invasive procedures of whatever surgical field is 10, and it doesn't move from that, even this conventional laparoscopy, and you bring the robot and you create 50, because there's a greater adoption in the technology and easy to use, well, then you're going to have those benefits for minimal invasive overall, and those costs spreads overall more for the robotics. So what do we have in regards cost? And again, these are the models when we have more on the cost in the urology field and the gynecological field. We don't have much in surgical field. But this is a study that was presented in 2011 in which they compared the cost within time of different modalities. So the composite cost, meaning the cost of all modalities within time from 2006 and 2009, did not change much, 4.1%. So there was not much change in the cost in those 3 years of difference. When we compare the transition on cost of robotic surgery from 2006 to 2009, we actually see a decrease in the cost. And most of this decrease in the cost is not a decrease in the operating cost. The operating cost is part of the equipment cost, the cost of all the ancillaries, the cost of the nurses, etc. But the decrease in the length of stay. So the decrease in the length of stay overall compares to the cost of the other type of procedures. So it compensates at the end. Now, when we talk about cost, these are just the cost calculated for the hospital perspective. It's really important when we do all this calculation. I'll talk a little bit more about that, about when we talk about the cost from the society perspective. Okay, so what's the cost of a patient not returning to work? What's all those added costs? So when we do all these studies and we do all those calculations, and again, they're assumptions. They're not kind of a solid data. They're just assumptions. When we calculate that, the lowest cost calculated for the society was in the robotic arm. Same thing that we see in the urology field. We have, a decrease in the postoperative hospital cost. We see in the first line for robotic assisted laparoscopy for partial nephrectomies compared to hand-assisted nephrectomies. We can see that the savings are in the length of stay. In another report, this is in Florida, it's really interesting on how much they save in the first 100 patients they did in a program in Florida using the Florida Hospital Association data. They calculate the average cost for inpatient stays around $1,800. Using the first 100 patients, which include hysterectomies and urological procedures, they calculated a reduced cost of $4,500 per hysterectomy and $1,500 for prostatectomies, a total of $267,000 just for the first 100 procedures. Now, can that compensate the equipment cost or the capital cost of the robot? Well, probably. Usually an average robotic program may perform like between 300 to 400 procedures a year. So what are the drivers of adoption for robotic surgery? So everybody, again, has the same controversy about cost and cost. And when we talk about cost, it's really important to talk about value. What's the value of a technology? What's the value of what we do? And how value is defined. So value is defined in generally as outcomes over cost. Yeah? When we do a cost-effective analysis, we're trying to compare two different technologies and compare the outcomes over cost. Okay? If we compare the outcomes of laparoscopy and robotic, they may be the same. It's a minimal invasive approach. Cannot get much better than that. Maybe a little difference, but not major. But we have the problem with the cost. Okay? But that will be one way of doing it. Now, can you do a cost-effective analysis between two similar technologies? Probably not. You have to do it different. There's different aspects that you have to integrate. When you put a cost-effective analysis into comparing these two approaches, you have to put into consideration how many physicians will use one approach versus the other approach. If you put that, maybe the results will be completely different, more outbalancing to the robotic case. So, is robotic surgery better than laparoscopy? The reality is both techniques are born to be together. You have to do known to be laparoscopy in order to do robotics. But what we really know is that conventional laparoscopy is demanding and with variable outcomes and adoptions among the surgeons due to the step learning curve. So this is the adoption that we have seen increasingly in urology and gynecology, in prostatectomies and hysterectomies. And we can see within time there has been more minimum invasive surgeries due to robotics, not due to laparoscopy, after the implementation of robotic surgical programs. One of the things that none of the papers talks about this is cost opportunities. And I think this is kind of a little personal slide, so I don't know how good it is. But in my perspective, as I mentioned, in the OR, some of these procedures require multiple surgeons. I do not use any surgeons or any first assist. I use a surgical tech to perform my robotic surgeries. So if I had a partner or I have someone, they could be doing something else. They could be treating another patient. They could be doing rounds. They could have a more efficient use of their time than helping me to perform the case. Two, time saving. The amount of time that is spent in rounds is not much. Most of the patients go home next day. So before we have the robots and laparoscopy, we have, when I was at Hopkins, we had the ward of 40 patients that had surgery. And probably there were, less of the volume that we're doing now in today's. So we have more ability to send these patients home early, and that also free times for us to dedicate ourselves to other, clinical duties. Also, really important is after, doing laparoscopy, I did all the radical laparoscopic, conventional laparoscopic for radical hysterectomies. At the end of those cases, my neck hurt, my hand hurt. If you have at the time I had intern first assist every 3 months, it's a constant pain that overall, I was thinking I will be able to do this when I'm 60. Should I be able to do this when I'm 70? One of the other G1 oncologists in practice, he's 75, he's doing robotic surgery, and he's like nothing, So his ergonomics are better. So surgical longevity from improved ergonomics is something that we can see with robotic surgery. Other drivers for adoption. Again, we mentioned about value. And value is not only about cost. What's the patient value? Well, efficacy, invasiveness, a less invasive approach that has adequate results. What's the surgeon value? The patient values is important for the patient thinks. Easy to use, yeah, not a steep learning curve, and that the patients go home fast. Hospital value, the patient value, the surgeon value, plus the economical benefits for the hospital. Call it increased market, increased share, increased profits. And the economic value will equate all those outcomes, the fewer complications, the reduced length of stay, the reduced admissions, and the return to normal activities. Again, the society perspective of the technology. So this is right now, how many robotic programs exist in Texas. We can see biggest concentration, Houston, Dallas, San Antonio, and Austin, but also moving programs out into El Paso and to the Valley. So robotic surgery is going viral. It's expanding. It's something that's going to stay. It's not going to go. Now, what happened in academic and residency programs? It's also starting in academic and residency program, and is still growing day by day, in which there's been surveys that residents are looking for programs that have a specific robotic training. So that's been something that has been actually looking to the curriculum for training residents, and not only in gynecology and urology, but also in surgery. So what advantages we have when we talk about the simulator, in which they can simulate real surgery with the system. That's a big educational equipment that the robot can provide. I'd like to present like 2 more slides about this. This one is about, and that same series for 1,000 patients, that's also an academic center. And actually they start comparing fellows, again, attendings, complication rates on their robotic surgeries. And the complication rate was, the same. Then the fellows start comparing, again, residents. So the residents were doing the procedures and compare the results about the fellows, again, with similar complication rates. What is that telling us? That the adoption of this technology is even easier for these residents. And when they become attendings, they will be probably more proficient. What's in the future in robotic surgery? Well, we're going to probably have smaller cameras with single ports, with multi-instrument ports. And that's probably the technology that will be coming in the future. So in conclusion, the rate of discovery of new technologies outpacing the ability of business, society, and healthcare to integrate and apply. Robotic surgery is but one example of such technology that may reduce operative morbidity, hospital stay, and recovery, while potentially improving clinical outcomes. But the question continues: at what point the benefits justify the increased expenses? Thank you very much. I guess questions.
The laparoscopic benefit for gynecology and for urology, for oncologic operations, had twofold. It seemed to be better for the harvesting and getting nodes, yeah, and also not damaging adjacent structures. Is there an advantage over that initial with the robot? For just minimally invasive and then adding the robot.
Yes, actually we have studies on, in the main studies that we compare are in the studies for staging for endometrial cancer or radical hysterectomy for cervical cancer. And the reports that we have done when they compared studies comparing both modalities, laparoscopy and robotics, the yield for lymph node recollection is higher in the robotics than in laparoscopy. And it's much higher. It's a complete difference.
That's interesting, because that's exactly what happened with laparoscopy. People expected fewer nodes, but actually there was a higher node yield.
Yeah, so you have better visualization, you can go under the iliac vessel, so you actually have a higher node recollection than in robotic, than in conventional laparoscopy. There was also decreased blood loss than conventional laparoscopy. So the average blood loss from a radical laparoscopic was averaging 100, 150. We can perform a robotic radical with 20 cc's blood loss. So rate of blood transfusion, not significant statistic, but a little bit lower. Length of stay is almost the same, 1 day. There's not going to be much change on on those aspects. But the yield for lymph nodes, the yield for less complications, less vascular complications, less urethral complications, optic nerve complications are lesser with the robotic surgery. One of the things that we have to think is in the learning curve. You know, most of the published data that we have, you know, what do? We adopt a new technology, and we in an academic center, we want to do 50 cases, and then we want to report it. Yeah. Let's remember that those 50 cases, sometimes 10 or 15 is the learning curve, or the 20 learning curve. And and then you want to compare that to laparoscopy that you have done for the past 5-6 years, and you don't have that learning curve. So it's really important when we're looking into all those statistics, to look into, experiences that are more mature than just pilot studies. Okay? But right now, the mature studies that we have a better outcomes on those aspects in cancer surgery.
Dr. Dent.
You kind of danced around one of the real ethical concerns of the adoption of minimally invasive and subsequent robotic surgery, which is the patients are going to the robot regardless of the outcome. And there have been some, for example, excellent urologic groups in Texas that had almost been put out of prostate cancer business, even though their outcomes are as good or better than any published robotic data, because the patient won't come to them anymore because they're not using the robot. And so the fact that this isn't really driven by outcomes at all, it's really driven by kind of a sexy marketing ploy to get patients to go where the sexy marketing is. It's probably, Dr. Stewart's not here, he's under the weather, but he believes we've actually failed as American medicine. American medicine, American surgery has failed its clients, has failed its patients because of the rapid adoption of robotic surgery, the absence of data, and a lot of people going to places just because they happen to have a little sign that says robot hanging out on the street.
Well, it's a valid perspective. I have done almost 1,000 robotic cases. I have only one patient that came to have robotic surgery with me because they saw me on a website. So, so it's a different perspective. So I don't have any patient coming with me saying, I want robotic surgery. They come with me because they have a cancer. And then when they ask me, how are you going to do it? I'll do it this way. And some patients say, well, can you do it open? And I tell them, if I do it this way, you go home next day, you recover better. Okay, so I don't have that, yes, most of the controversy was like how aggressive was this company to market the technology. Okay, so yeah, there's no doubt they did that. In the case of prostate or radical prostatectomies, you can see both ways of the coin. You can see, those also physicians sending patients for IMRT and not for surgery, for having economical convenience. Yeah, and they may have similar outcomes. Again, unfortunately, that's sometimes how decisions are made, and again, I'm not saying they're ethical decisions. In the case on here in town, on robotic prostatectomies, mainly here the urologists in town have joined and just sent to one or two physicians to do all the robotic prostatectomy so they can have a high volume. Remember, the high volume is what makes those surgeons to be better surgeons than those ones that do once in a while prostatectomies, etc. The high volume is what makes them expert surgeons. And if you can say, sometimes robotic surgery has created those high volume surgeons and make those different outcomes. So again, we can go both ways on the coin about the marketing part. In my perspective in gynecology, I have no patient that comes with me or leaves me if I do not offer robotic surgery.
Dr. Ramos.
Excellent talk. The issue of have we failed the American people by doing minimally invasive surgery? Well, it's the other way around. I think that in minimally invasive surgery, the American surgeons have minimally invasive surgery for fun. There is a resistance to do it, mainly in some of the academic centers. For some reason, even though there is more evidence, more studies on this particular issue than any other that over and over, every journal has an article about comparing open to laparoscopic surgery in color. And still, a tremendous resistance from academia. No, it's for the devil.
My grandfather used to say that same thing. You know, you met my grandfather. But you know, that's the reality. So one of the things that we're saying here is that, you know, you can put it in different ways. The question is this: okay, if you think laparoscopy should be the standard, well, why not everybody's doing laparoscopy? Because it's hard, because it's not well adopted. So if you say, well, now robotics the devil, but everybody's doing robotics and everybody's going home early, where's the failure? Okay, where's the failure for that? So one of the problems in medicine is variability. You know, all the variability that we do in care. You know, surgical variability is really hard to demonstrate. So the way one do the surgery compared to the other one do the surgery, the outcomes that they have is completely different. Someone that is proficient in laparoscopy doesn't mean that all the surgeons are proficient in laparoscopy. They're counted. The ones that make the reports are actually, you know, experts, master surgeons in laparoscopy. Yeah. But if you want to put that to, you want to, basically make a better constant, you provide better tools for physicians to create those outcomes. And I think robotic surgery provide those tools to make it more even, or less variable outcomes in surgery to the population.
Probably it's not just robotics, it's the technology. There's a big technology difference between laparoscopy 20 years ago and laparoscopy now. You know, colon surgery back then was an endo loop around the vessels, not a ligature. 20 years ago, correct. Right. Dr. Peterson.
I was just going to say that, the adoption, and I was much like your brother, which was, the robot really didn't have a place, and I think general surgeons were they felt left out because this was a solution without a problem for the general surgery world. Up until recently, I think, and even in bariatric surgery, when I went and first trained with the robot, we watched them do it laparoscopically, and they're doing a hand-sewn laparoscopic GJ, which I do as well, and I do it faster laparoscopically than that. That having been said, the ergonomics, the impact that it has on your body over time, you start to understand that actually is different, and that the longevity that you'll have is a big part of that. Now today with the new technologies, a vessel sealer, which is the ligature essentially, powered stapling coming very shortly, and the Firefly. I mean, those technologies are here now. They do change some of the things that we're looking at. So I don't think we're hurting the American public. I think the laparoscopic postoperative was brought in, with patients driving it forward, and I would still say today that that's a better way to do the surgery than it is. That having been said, this may have pushed it as well. But when the outcomes are better or as good or better, then I don't know that we're really hurting the public. It's a marketing tool for sure. Maybe hurting the other surgeons who are adopting it, but
What happened to cardiac? Because I thought that was going to be one of the major uses.
That was the
as
first
far as suturing the vessels and suturing the valve in. I mean, we all thought that was going to be
the problem is volume. So the first surgery on telepresence was actually cardiac surgery. So the problem was volume. We tried, like when I was in El Paso, we tried to train two cardiac surgeons, thoracic surgeons in doing that. They do 3 cases and then they say, we're not doing it anymore. Again, they didn't want to put the time, and the problem is the volume. They didn't have the volume, enough volume to get proficient. So in academic center where they may have this volume, there's some centers in Cleveland Clinic where they may continue doing, cardiac surgery, but they're just so specific centers where they can concentrate large volume so they can continue doing it. So I think it's a matter of volume, mainly.
Dr. Easter, has the military backed off the robotic surgery kind of portrayed?
They not only backed off the robotic surgery, they backed off that whole technological idea. With the unmanned vehicle, part of that unmanned vehicle platform, everything. It was too expensive.
All right, thank you very much.